Thank you, Val. Welcome, everyone, and especially Dr. Klompas. And what I want to do first is just lead up to an introduction, is give a bit of historical context for our issue of evidence for airborne transmission. And I want to start with SARS-1 here in Ontario, 2003. We saw at that time that, just a second, I have, okay. In the publications that came out afterwards, they indicated the possibility of airborne droplet transmission, which was an interesting combination there. And later, when they analyzed the rate of infections amongst those who wore N95s versus surgical masks, they found the N95 mask offers more protection than surgical masks, even though the p-value at that time did not quite make statistical significance. But remember that number, it comes up again. Then afterwards, we had the Campbell Commission in Ontario, which talked about the conflict between the two disciplines of health and safety and infection prevention and control. And Justice Campbell recommended that the precautionary principle, which is the modus operandi of health and safety, should prevail. And although changes were made after this Royal Commission in Ontario, most of those changes eventually eroded, and by the time the pandemic happened, most of them were gone. Now, H1N1 in 2009 was an opportunity to apply what we learned from SARS-1. And during the first wave, things went quite well. N95s were required for any healthcare worker with any suspected patient. And PAPRs, powered air purifying respirators, were recommended for aerosol generating medical procedures. Once the second wave came, the vaccine was out and many of these precautions were no longer applied. Then we had, at the same time, just before the pandemic in 2009, we had an RCT happened in Ontario, which looked at comparison of N95s and surgical masks, and it found that there was no difference. However, when you looked at the data, one of the things they found was that almost 10% of the people exposed had evidence of H1N1 exposure. However, this was before the pandemic actually hit Ontario, and so they thought perhaps it was circulating beforehand, or else that the seroconversion cross-reaction happened. And also with influenza-like illness, it was a completely opposite picture. Amongst the surgical mask group, 9 of them were infected, whereas only 2 in the N95. And although this was unexpected, it was not statistically significant. And even though the p-value, again, was p equals 0.06. And that also begged the question that if N95s aren't working as they should, we should find out why, fix that, or get better protection. And in 2020, the same group proposed another RCT to compare medical masks versus N95s for COVID. We have not heard how this one is going. Then in 2012, we had MERS, Middle East Respiratory Syndrome. And here, the assumption was human-to-human transmission is possible, but only few such transmissions have been found among family members, except in healthcare situations where healthcare workers have experienced human-to-human transmission. And based on this, surgical masks were recommended as healthcare protection. So this is a change in the approach from N95s to surgical masks. Now, it's interesting to note that in a recent study, 59% of imported camels in Egypt were positives for MERS, and 25% of the traders had antibodies specific to MERS, even though none of them had any history of developing the disease in the last 14 days. So it's there, but it's not clinically evident. And in 2014, in Singapore, a conversation was held whether we should be using surgical masks or N95s for MERS. And the surgical masks won out that conversation. And then in 2015, there was a particularly large outbreak of MERS in South Korea, and was entirely nosocomial, and the infection management and policy failures were blamed. And when they looked at the measurements for surface and air, they were convinced that it was both surface and air transmission, and that the adequacy of current infection control procedures were questioned. Now, there's been work also in Toronto in 2015. There was some work showing that influenza virus could travel more than 1 meter away and end up in the breathing zone of healthcare workers. Also, we had a summit here in Toronto in 2017, which brought together experts from all over and to discuss this. However, because of bureaucratic gridlock, as I like to call it, nothing came of it. And then in Toronto, again, in 2019, measurements were taken for influenza viral RNA in droplets and what they call droplet nuclei or aerosols. And basically, two interesting statements here was, when there is doubt, both droplet and airborne precautions are generally employed, and that the relative contribution of each route to overall transmission of influenza is unknown, leading to a debate regarding the important modes of transmission and appropriate means of transmission prevention. And this is 2019. Also in 2019, some of the same authors put out an article about different experts from different fields working together: aerobiology, microbiology, biophysics, engineering, infection prevention and control, and occupational health, using a number of different tools and different types of evidence. However, in January and February of 2020, even though we were using N95 respirators at that time, which were there was a severe shortage. It was a holdover actually from the H1N1. Soon after that, it was suggested that Ontario was being wasteful with their N95s, which should be safe for aerosol generating procedures. And for that reason, and for others, Public Health Ontario downgraded the protection for healthcare workers and ended up using surgical masks. Now, when the evidence was provided for this, we found that the evidence was generally poor. It was either an appeal to authority or jumping to conclusions early. It was even suggested that because no healthcare workers in British Columbia had been infected, that therefore droplet precautions were sufficient, even though this wasn't true. And even at the second revision of this evidence, it was definitely not true, but it was still left in. There was also the absence of evidence as evidence for absence fallacy was used, selection bias for picking studies that could not find virus in the air due to poor sampling. And the references for droplet were also interesting because two of them were contrary to what it was cited for. And in the others, the word droplet was not used, and close contact was assumed to mean droplet and not aerosol. And at this time, Dr. Klompas was also quoted by our public health people, and basically at that time, he had said that the balance of evidence seems inconsistent with aerosol transmission of SARS-CoV-2, as particularly in well-ventilated spaces. And the balance currently available of the available evidence suggests that long-range aerosol transmission is not the dominant mode of SARS-CoV-2 transmission. And this was carefully worded, and is probably still true because well-ventilated spaces do not easily transmit disease, and long-range aerosol transmission is not the concern. It's the aerosol transmission in the short range or within room. And that led to this confusion where people were claiming all types of things, and each one of them is partially true, but not any one of them has the complete picture. And as late as that should be 2021, January 2021, it was stated that there is no evidence that SARS-CoV-2 is airborne. And in fact, if you went into a healthcare facility at that time wearing an N95 or higher, you were asked to remove it and put on a medical mask instead. In fact, the month after, the Public Health Ontario listed all the hazards of wearing an N95. And when we saw the infection rates amongst healthcare workers, we can see in the blue graph here, the blue line, that for the first two waves, healthcare workers were infected at a higher rate. Once the vaccinations came in, that rate dropped. However, once Omicron came, they shot up again, and then people started not testing as often, and then they stopped counting healthcare workers who were infected, so the data ran out. But here was the peak when it was stated that there was no evidence of airborne transmission. Now, Dr. Fauci at Harvard Grand Medical Rounds stated about his change of mind of how things, how the virus was transmitted, and basically said, we really got to realize from day one, you don't know it all. You've got to be flexible enough to change your recommendations, your guidelines, your policies, depending on the information and the data that evolves. Because if you look at what we knew in February compared to where we are now, there really is a lot of differences. The role of masks, the role of aerosol, the role of indoor versus outdoor, closed spaces. You've just got to be humble enough to realize that you do not know it all from the get-go, and even as we get into it. Dr. Klompas was also participating in that grand rounds, and I have a little clip here.
Yeah, no, I was going to say my lesson is humility. That what's been remarkable is how much has changed, how much has been assumed, and therefore has rapidly been overturned. And that what we all, I think, need to appreciate is that what we think is true today might not be true tomorrow. And therefore, as we go about saying what we ought to do today, that should be aligned with that recognition that it might be completely wrong. And that therefore we need to be expansive, we need to embrace the sort of the caution principle as we set about creating our next steps. And I think that's the lesson to then apply to the inevitable next pandemic that we face again, is to go in there not with certainty, but with humility. Yeah, no, I was going to say...
Oops. Previous. Yeah, and as a bit of a biography, Dr. Michael Klompas is Associate Professor at the Harvard Medical School in Infectious Diseases and also works at the Brigham and Women's Hospital Division of Infectious Diseases in Boston. His clinical interests include emerging infectious diseases, among other things. And you can read here all his recognitions. And I noted that on his education that he went to school at the University of Toronto, which was a surprise to me. And I'm not sure if he's Canadian or not. Maybe he can tell us. Here's the top 6 items in his list of bibliographies. And there's 325 publications, and the one that I especially, recent one that I especially found very helpful was the prevention of SARS-CoV-2 and respiratory viral infections in healthcare settings, current and emerging concepts, a review in current opinion in infectious diseases. And with that, I'll turn it over to Dr. Klompas. Very much welcome.
Okay, fantastic. Well, thank you very much for that amazing overview. I'm not sure I have much to add. I think you covered all the prime material. So what I'll be doing, I think, simply is adding some color to, I think, the very nice review that you've given us for the evolution of our understanding of transmission science over the past 20 years. I am Canadian, happy to share that. And as you've put out, I went to University of Toronto for medical school. I went to high school in Toronto. My parents are still there, so it's near and dear to my heart. So I'm pleased to be able to speak to you today. I'm going to share some slides. Go for it. Okay, are my slides showing? Are people seeing that?
Yes.
Okay, fantastic. So let's go for it. So we're going to talk about viral transmission in the workplace. These are my disclosures. And I just want to start off by taking a pause and recognizing that if we look back upon the scope of the past 2.5 years, that collectively as an international community, we've suffered an enormous burden with literally millions of deaths. It's over 1 million deaths inside the United States, almost 50,000 deaths in Canada. And while we've certainly have learned a lot, we've paid a heavy price along the way. Now, it turns out different countries have had different experiences in terms of the public health impact of the pandemic. This is notable. Here's a cumulative deaths per million people across a selection of countries around the world. And I want to highlight really 2 things. Number one is that the United States has done particularly poorly. We have a collective mortality rate per capita that's really one of the highest in the world. And by contrast, you in Canada, we as Canadians, have done far better. So you can see our per capita mortality rate is far lower. And there are multiple factors, I think, that explain that. Some has to do with vaccinations, some has to do with openness to public health recommendations, masking approaches, so on and so forth. But it's striking to see that different places, different countries landed with different ways, different countries coped with the pandemic. So we refer to here to different rates of vaccination around the world. And basically, this graph is a complete inverse of the cumulative mortality rate that we saw on the prior slide. In other words, Japan had the lowest cumulative mortality rate, and they had the highest vaccination rate. And conversely, the US, with the highest mortality rate, has the lowest COVID booster vaccination rates, and Canada is somewhere in the middle. This being a discussion around occupational risk, I did think you might find this interesting over here. This is an analysis from the state of Wisconsin, where they analyzed about 350,000 adults with COVID and tried to look at the relative incidence of COVID for different kinds of occupational sectors, as well as roles within those sectors. And shown in gray over here are some of the highest risk occupations that have been highlighted by this particular analysis. Some of the commonalities you might notice amongst these roles is, first of all, the necessity of direct face-to-face contact between individuals, and number 2, the necessity or the common association with other socioeconomic factors that might drive risk, such as being in more crowded housing, the necessity of taking public transport to work, which also might add collateral risk to above and beyond what's actually faced in the workplace itself. But I want to hone in on the question of the day, which is around respiratory virus transmission. And as John beautifully outlined, there's been a long-term controversy in the infection control field, the infectious disease field, maybe less so in the occupational health field, around the mechanism of spread of respiratory viruses. And the question has been, are viruses spread by droplets or by aerosols? So here's an amazing photograph. It comes from a researcher at MIT in Massachusetts, where she's been able to capture in a single image the different kinds of respiratory emissions that we're talking about. So shown in green are the droplets. So these are larger respiratory particles that are classically thought to have been large enough that by virtue of gravity, they will rapidly fall to the ground within a radius around 3 to 6 feet from the source individual. And that's in contrast to those shown in red, which are the aerosols, which are much, much smaller respiratory particles, which again, by traditional teaching, are small enough and light enough to remain suspended in the air for long periods of time, to be carried on air currents across long distances, well beyond 6 feet, and to potentially infect people across a room, to be able to circumnavigate a mask and to infect people despite wearing a surgical mask. So this is sort of the historical debate has been which of these two kinds of respiratory emissions, the droplets or the aerosols, predominate in infection transmission. And the answer, of course, is that it's both. We're human beings. We're not machines. We're not a dichotomous system, but we, as a living entities, we exist on a continuum. So it turns out, in reality, people don't put out just droplets or just aerosols. They put out respiratory particles in a range of sizes that span all the way from the very small inside the aerosol range to the very large in the droplet range. There is no hard and fast single point of division to say that this is an aerosol and this is a droplet. Rather, it's a continuum. You will note, however, that the majority of respiratory emissions is actually in the smaller range, in the aerosol range, not in the droplet range. And it turns out that if you go ahead and you sample the air inside of healthcare settings, being at a clinic or a hospital or an emergency department, a long-term care facility, depending on what's going around in society, you will be able to recover respiratory virus from the air. So again, depending on what's circulating, that might be SARS-CoV-2, it might be influenza, it might be respiratory syncytial virus, it might be rhinovirus, we heard about MERS. These are all possible. And the reason I'm saying this is partly to affirm the fact that you can find these viruses suspended in the air in small aerosols, and it's part of the evidence package towards the importance of aerosols in transmission. But it's also to point out that basically everything I'm going to say to you today applies to all respiratory virus. It is not specific to SARS-CoV-2. And as you see, as I develop the discussion over here, I'll give you some examples predominantly from SARS-CoV-2, but I'll be throwing in some examples as well from other respiratory viruses as well, simply to show that I'm talking about a common theme across respiratory viruses. So the question has been, okay, very nice. If people can create aerosols, occasionally you can isolate virus from these aerosols, but are they actually clinically important? Do they lead to infection? So I'm going to begin with an animal study showing that yes, an aerosol-borne virus can lead to infection. The way this study is done is that you take an infected ferret, you put it inside the bottom cage. So the ferret over here, this was done once with SARS-CoV-2, once with flu. Then you put another uninfected ferret in the top cage. And the way that this is set up is that you have a one-way flow of air. And in order for the air to go from the bottom cage to the top cage, it literally has to take 4 90-degree turns and go up 1 meter. Now, there's no droplet in the world, which again is governed by gravity, that's going to go across 90-degree turns and straight up in a vertical fashion by 1 meter. So it's only aerosol-borne virus that would be able to expose the uninfected ferret and potentially infect it. When they did this experiment with SARS-CoV-2, 2 out of the 4 exposed ferrets got SARS-CoV-2, 4 out of the 4 exposed ferrets got influenza. So this is animal-based demonstration that yes, aerosol-borne virus can lead to transmission of infection. But you're saying to yourself, very nice, but I'm not a ferret, I'm a human being. Does this apply to human beings, or is this simply an animal phenomenon? Well, it turns out that in the human field, we actually have the almost identical experiment in the form of quarantine hotels. Now, you'll remember how this worked, that there were some countries, particularly in the Far East, as well as Australia and New Zealand, where the policy was during the height of COVID, that if you were traveling in from abroad, that you had to be quarantined in a hotel for 2 weeks or more until it was absolutely clear that you were negative before you were let out free into society. Now, these quarantine hotels were very strict. You had to remain inside your room the entire time. There was video monitoring to make sure people did not leave their rooms. You were fed by a worker who came door to door to deliver food and take out your used materials. So there was no interaction at all between travelers who were in different rooms. And yet, nonetheless, we had reports from around the world in multiple quarantine facilities of one traveler being infected by another, proved by genetic sequencing, by genetic fingerprinting, despite the fact that there was no interaction. What was thought to have happened was that the infected individuals would be inside their room for long periods of time, right? They were literally there for 2 weeks, continually. And as they were continually emitting respiratory-borne virus, it was accumulating inside the room to higher and higher levels of concentration. And then the worker comes along and opens up the door. That leads to a rush of air from in the room to out the room into the corridor. And then as the worker then closes that door and goes over to the next room, one door down, and that door is opened, some of the air from the corridor that's now been enriched with respiratory-borne virus goes into the other room and ultimately infects the other person. Now, again, there's no droplet in the world that's able to go out a door, hang a left, hang a right, and go into another room. So again, this is evidence over here of only an aerosol will be able to accomplish this particular direction pathway. Now, what's striking about this is that nonetheless, it turns out to be odd, unusual to see transmission from room to room. It certainly has been well documented that it can happen, but it's not the commonality. Like, we don't often hear about somebody in an apartment building being infected by the family next door. Again, there are certainly cases where it's been documented to happen, but it's the exception rather than the rule. So what was extraordinary about these quarantine hotels where this was documented to happen again and again? Well, I was recently staying in a hotel in Atlanta. It happened to be a nicely newly renovated room, and I was carrying along with me my carbon dioxide monitor, which I bring along to understand what ventilation might be in a certain space and to understand the dynamics of our world. And so this is the recording of the CO2 levels in my hotel room from when I arrived at 6 p.m. Until I left around 7 or 8 o'clock in the morning the next day. And you can see the steady, gradual, stepwise accumulation of carbon dioxide, which in this case would be a proxy for aerosol-borne virus, leading to a higher and higher concentration in that room. So you can imagine somebody who's in a quarantine hotel for literally 2 weeks can lead to an enormous amount of accumulation of virus inside of the room, such that enough could escape when you open up that door to be enough to infect the person next door when they open up the door to their room. So the other point of evidence that really points to the importance of aerosol-based transmission is our recognition that a substantial fraction of SARS-CoV-2, and this happens to be true of influenza as well, is transmitted by pre-symptomatic or asymptomatic individuals. Now think about this. The kind of mechanism that leads to droplet formation is coughing, spluttering, sneezing. If you're asymptomatic, that's going to be very much the exception rather than the rule. Yet the fact that so many of the infections, that CDC's estimate was about 2/3 of infections were spread by asymptomatic or pre-symptomatic individuals, again, that suggests that most of the transmission was not taking place by coughing or by spluttering or by sneezing. And that's another indirect clue to the importance of smaller respiratory particles in transmission. The fact that so much of transmission occurred prior to the development of symptoms is paralleled when you measure actual viral levels inside of individuals. And over here we come with a particularity of SARS-CoV-2 compared to other coronaviruses. And that particularity is that in SARS-CoV-2, in contrast to some of the other viruses, viral levels are highest before symptom onset. Now we know there's a clear correlation between the amount of virus you're exposed to and the risk of transmission. The more virus you're exposed to, the greater the chance you're going to get infected. And with SARS-CoV-2, the greatest amount of virus is present before the symptoms begin or immediately after the symptoms begin. And that's one of the factors that made SARS-CoV-2 so successful in spreading, is that people were maximally contagious without recognizing that they were infected. Here is further evidence now from the Omicron era, mirroring the same message over here, the important association between quantity of virus and risk of transmission. This is looking at around 4,500 household contacts, around 2,000 people with Omicron infection, and it's correlating the amount of virus present with the rate of transmission risk. And so the more virus present, the higher the rate of transmission. Now that's going to be a theme as we discuss mechanisms of transmission. The more virus you're exposed to, the greater the risk of transmission. So keep that in mind, because you're going to see it's going to be an important theme that we'll return to again and again. So in practice, this is the way that most transmissions felt to take place. You have two people who are feeling perfectly fine, who are interacting in close fashion, breathing and talking and emitting respiratory particles in a normal fashion, yet when they're infected, without them knowing it, they carry this virus. It's carried over to the other person who inhales it, and therefore it leads to infection. Now, we know a number of factors affect the amount of aerosol that you generate, and therefore the amount of virus that you might be emitting. So the volume of your speech is an important factor. Here is a number of people reading the same passage from a book, being asked to speak loudly or quietly or somewhere in between. And you can see that when you speak loudly, you emit far more particles compared to when you speak softly. You'll note again, though, that the majority of the respiratory particles that are emitted are the smallest ones over here, again in the aerosol range, rather than these over here in the droplet range. But again, it is a continuum. The other factor that really impacts viral aerosol transmission or emission, I should say aerosol emission, is activity level. So this over here is a study that measured the amount of aerosol emitted by an individual as a function of their activity. So if quiet breathing is 1, if you're talking, that increases your aerosol emissions 35-fold. Exercising, almost 60-fold. Shouting, 160 times more aerosol compared to quiet breathing. Forced expiration, over 200 times increase. Coughing, almost a 400 times increase in the amount of aerosols that you emit. The other factor that we've learned is that there is tremendous person-to-person variation in the amount of aerosols that people transmit. So some people, this study is done here with influenza, some people put out very little aerosol and virus, and some people over here put out enormous amounts of aerosol and virus. Now you can start to put together in your head, you can see over here some of the factors that might lead to a super spreader event. Right? If you happen to have an individual who's right at that early stage of infection, where they have a maximal viral load, who is engaged in some vigorous activity, shouting or laughing or talking vigorously, who happens to be one of those individuals who, by virtue of their physiology, is a large respiratory aerosol and virus emitter. Those are some of the factors that might contribute to a super spreader event. We do know that that the severity of illness can also be a contributor. There's a little bit of subtlety to this, which is that this is only true in the early phase of disease. But this over here is looking at secondary attack rates from outpatients, so people with milder disease, by tracing the infection rates amongst 3,500 close contacts of almost 400 COVID patients in China. And you can see over here that if the source individual is asymptomatic, a low rate of transmission, but much that increases as their symptoms, their likelihood of coughing, sneezing gets greater, because that leads to more aerosol emission, more respiratory virus and respiratory particle production. So the question I think that has really bothered the field during the early part of the pandemic was that the traditional teaching had always been that for an aerosol-based organism, and again, the classic teaching over here was something like measles or tuberculosis, that an aerosol, because it can carry well beyond 6 feet, that everybody inside of a room who's exposed to somebody who has an aerosol-based pathogen is at risk of getting infected and could be infected. And so the fact that in practice, during the early period of the COVID pandemic, that we were not seeing much long-range transmission in practice, made people wonder, how could you reconcile that with an aerosol-based mechanism for SARS-CoV-2 transmission? And the answer, I think, is now pretty apparent. The answer is dilution and diffusion. So this over here is a image over here of a cough. This is a mock cough over here. And look at the aerosol plume over there coming out of the source individual at 3 feet, and compare it to the way the plume looks over here at 6 feet and at 12 feet. Now, it's clear that that respiratory emission is going well beyond 6 feet. So certainly one is at risk beyond 6 feet. However, compare the density of that respiratory plume at 12 feet compared to 3 feet. You could well imagine that if you expose this individual who's infected at 3 feet, your risk of getting infected is going to be much, much greater compared to if you're only exposed at 12 feet. And the reason being because you're exposed to much, much more virus if you're at the 3 foot kind of a range. In other words, distance, even with an aerosol-based pathogen, is protective because it allows for diffusion and dilution such that the amount of virus which you exposed is diminished. This can be documented again. Here's an influenza demonstration of this phenomenon. Over here, this is looking at the amount of viral recovery at 1 feet versus 3 feet versus 6 feet. And you can see that, yes, you can recover influenza virus here all the way out to 6 feet and beyond, but the amount that you recover steadily diminishes on almost an exponential scale. Now, this is not just a matter of theoretical biology. We actually have epidemiological studies bearing out the protective power of distance. This is one of my favorite studies of the pandemic over here, where our colleagues in China were able to do a remarkable study where they were able to link together people's medical records with their train travel records. And they were able to work out that if you went on a long distance train and you had the misfortune to be sitting right next to somebody who had COVID, you had a 3.5% chance of getting infected yourself. However, if you were only 2 seats away, that's 1 meter, it's about 3 feet and change, your risk of getting infected literally dropped in half. So from 3.5% down to 1.7%. And if you were 3 seats away, it went down again, down to 0.4%, almost 1/10 of the original risk you experienced by being right next to the individual. So you can see over here, again, borne out in actual epidemiological studies of real human beings, the protective power of distance to decrease transmission risk. Now, because these were train travel analyses, they could also take into account how long you were on the train, and therefore what the issue of how duration of exposure might affect transmission risk. So if you were on a half-hour trip or a 1-hour trip, you had a 0.2% risk of getting infected. But if you were on that train for 8 hours with the infected person, your risk went up almost tenfold to around 1.5 to 2%. And the reason, of course, is that the longer you're exposed to the person, the more virus you'll be exposed to, the greater the amount of viral exposure, the greater the risk of transmission. There is one exception to the protective power of distance. What's shown over here is a picture of the Skagit Valley Choir. Now, you might remember this very, very tragic event. This happened early on in the pandemic. It was in March 2020, where 61 members of this community choir got together to practice. And it turned out that one of them, unbeknownst to them, was infected with COVID, and 53 of the 61 people there ended up getting infected. So an 87% attack rate. 3 were hospitalized, and tragically 2 died. So when they did the investigation, it turned out, of course, that one person was positive. They were together for about 2.5 hours. This was before masking was widespread, so there was no masking. The cases spread broadly throughout the room, as you might imagine, that very high attack rate. But the key factor was this, was that they went and measured the quality of ventilation, and it turned out it was exceedingly poor. The way they quantified that was in the amount of air exchanges per hour, which in this place was quantified around 0.7 air changes per hour. To give you some sense of context, in the hospital, we require a minimum of 6 air changes per hour, and various settings sometimes more. So this was literally about 1/10 of the quality of ventilation that you might get inside of a hospital space. The problem with poor ventilation is that it allows for accumulation over time of the amount of virus in the air. We saw that with the quarantine hotels. I showed you that demonstration of CO2 accumulation in my hotel room. And so that's the phenomenon in a poorly ventilated space, is that with time you get more and more accumulation of virus because the air is not being turned over. You're not diluting that space with fresh, uninfected air. And that therefore, by virtue of time, you get more and more virus inside the air and more concentration, and therefore more and more risk to everybody throughout the room of getting infected. Another demonstration of I would say the risk of poor ventilation and the benefits of better ventilation was shown in this very famous cluster of infections that took place in a restaurant in China. The story over here was that patient A1, shown over here, had just arrived to the city from Wuhan and was, unbeknownst to themselves, was infected. Ended up infecting 4 other people at their table, 3 people at the table to the left and 2 people on the table to the right. The story over here was that in this particular restaurant, there was an air conditioner on the wall over here. There was blowing air from right to left. So the air was going this way. And then there was an exhaust fan on the opposite wall, but it was closed. So what happened in practice was the air was going from the air conditioner all the way across these 3 tables, bouncing off the far wall and then coming right back again. And that's felt to be the way that the air was traveling. And this ended up creating basically a circulation loop in the back part of the restaurant over here that was leading to, in essence, a very poorly ventilated space because there was no additional air coming into that circulation loop, leading to very high amounts of virus being concentrated in that one part of the restaurant. What I didn't show you in the prior slide was, in fact, that this restaurant had many, many more tables. There were another 68 diners present, and none of them ended up getting infected. So what this shows you is that if you are right in a very poorly ventilated space, as was the case over here for the back of the restaurant, there's a high risk of transmission. 9 out of the 20 people at the back of the restaurant infected, 45%. But so long as you get a little bit of dilution in the air, that substantially decreases the risk of transmission. And so amongst the other 68 diners, none of them got infected. Likewise, the waiters, who of course did go to the back of the restaurant to serve, to clear, they did not get infected. And probably their protective factor was brevity. Because they were only in the back of the restaurant for a short period of time, therefore their risk of getting the virus was diminished. Now, they went and estimated what were the air changes in the back of the restaurant. And lo and behold, it turned out to be the exact same number as in our choir example. So 0.7 air changes per hour, which again, to remind you, is 1/10 of the minimum that we expect in hospitals. So the take-home message over here was that poor ventilation really facilitates transmission risk, but improvements in ventilation can substantially decrease transmission risk. I'd like to tell you about another cluster over here to try to bring out the powers or the benefits, but the limitations as well of outside air. So this again was a cluster from China. This was a cluster of 31 infections amongst 300 people who attended an outdoor Buddhist ceremony and lunch in eastern China. And it was all traced to one pre-symptomatic attendee. Now the story was that this particular ceremony took place out of town, and people had to get there. And they could get there in one of 3 ways. There were 2 private buses, or you could go by private transport. Now, people who traveled on bus number 1, 24 out of the 68 people on the bus end up getting infected, so a 35% attack rate. As you can imagine, the pre-symptomatic infected person was on bus number 1. Strikingly, though, the people who traveled in bus number 2, all 60 of them, none of them got infected, despite the fact they were at the same outdoor ceremony. It really suggests that it was the transport time, the bus, that was responsible for the transmission, not the face-to-face time outdoors. Amongst those who took private transport, 7 out of 172 were infected, so 4%. But it turned out that on history, all 7 of those people reported that it had close face-to-face contact with the infected individual at the ceremony. So I think what this tells you over here is about the risk, or the great increase in risk associated with a poorly ventilated indoor space. The fact that when you're outdoor, your risk is substantially diminished, but it doesn't come down to 0 if you're face-to-face at close distance for long periods with the infected individuals. So if you think of this from a schematic point of view, if you're in a well-ventilated outdoor area, then there is a dense viral plume just at the source, but it rapidly dilutes at distance, so you're really only at risk if you're literally right in the face of the infected person. If you're in a moderately ventilated indoor area, then you get the dense viral plume at the source, but you get gradual dilution with distance. So there's some marginal risk throughout the room, but it's substantially diminished. And by contrast, if you're in a poorly ventilated area for a long period of time, it leads to a dense viral cloud throughout the room. Everybody in the room is at high risk of getting infected. One limitation around the quality of ventilation is time. And this was brought home to us by an analysis we did in our hospital, where we asked the question, if you have the bad luck to be admitted to a shared hospital room where the person in the bed next to you is unbeknownst to have COVID, what's your risk of getting COVID? So we identified 25 patients who were diagnosed with COVID after admission to a shared room, and there were 31 potentially exposed roommates. Now, these roommates were at least 7 feet apart. There's a curtain in between them, and our rooms have at least 6 air changes per hour. However, the people who were in these rooms were together for long periods of time. The median duration of time together was 18 hours. And we ended up seeing that 39% of people got infected. I think the take-home message over here is that even in a moderately ventilated area, which I would call 6 air changes per hour, that's moderately ventilated, with great duration of exposure, you can still get transmission taking place. And parenthetically, this is the reason I think why transmission risks are so high amongst household members. It's partly because of intimacy, that people are close together. They might be sharing a bed, they might be sharing food, they're sharing meals together, face-to-face talking, hugging, etc. But in addition, people are spending a lot of time together, and that cumulative exposure therefore leads to increased transmission risk. Now, the importance of ventilation has been known to medicine for more than 100 years. Here's a sign from the 1918 flu epidemic. Keep your bedroom windows open to prevent influenza, pneumonia, and tuberculosis. And here's one of my favorite photographs over here. There's an outdoor ward, again, during the First World War in England, in order to try to mitigate the transmission of influenza. And all this brings us to the question of how good is your mask? Given all that we've covered so far, what's the protective power of a mask? So let's dive into that. We're going to start again with an animal-based study. This one is done with golden Syrian hamsters. And the way that this experiment is set up is that you take a golden Syrian hamster who's infected, and you put him in a cage. Then you put some uninfected hamsters in a cage that's right next door, and you have a one-way flow of air from the infected hamster towards the uninfected hamsters. Now this experiment was done 3 ways. So first of all, there's no masking. Then you put a mask on the source. Basically, you cover the cage with a regular surgical mask, and then you put the mask on the exposed over here. So you put the mask over the cage of the uninfected Syrian hamsters. And you can see over here the following. If there's no masking at all, then 10 out of the 15 exposed hamsters got infected, 67%. If you put a mask on the source, so over the infected golden Syrian hamster, you drop the infection rate down to 17%. So a substantial decrease. Likewise, you put a mask on the exposed, you can drop that infection risk down to 33%. So what you're seeing over here is that masks substantially can reduce transmission, but they do not eliminate it. Here is the human equivalent of that same kind of analysis. This was done from a contact tracing study in Johnson County in Iowa, where they identified 969 close contacts of 431 people with COVID-19, and they looked to see what was the transmission risk as a function of whether one, both, or none of the parties were wearing masks. So if neither party was masked, there was around a 26% rate of transmission. If just one of the parties was masked, you drop the transmission rate down to around 20%. If both parties was masked, you drop the transmission rate down to around 12%. What you can see over here is that there is clearly a stepwise protective factor associated with regular masks. They are certainly helpful, but they do not eliminate transmission risk. What's going on? Why is that? Well, we can look to studies that have measured particle penetration behind masks. Here is a formal evaluation of a surgical mask particle penetration. And the way this works is that you have a measurement system to measure particles that are going behind the mask. And you have the test individual wear a mask and then go through a number of different activities. So bending the head, reading, turn the head side to side, up and down, what have you. And you can see that as a person moves around, you can measure the amount of particle that's getting behind the mask. And the overall message over here was that with a regular surgical mask, it only blocks around 38% of the particles to which a person might be exposed. So, okay, so that's good. That's going to reduce your risk of transmission by 38%, but it's not going to eliminate it. And that correlates well with what we saw on those transmission studies with the hamsters and in Johnson County with the 0, 1, or 2 masks. This is parallel as well by studies measuring SARS-CoV-2 in the air as a function of whether you wear a mask or not. They found basically the same finding over here, that somebody who's wearing a mask, that reduces their SARS-CoV-2 emissions by around 50%. And that turns out to be the theme over here, that a regular surgical or medical mask will reduce viral exposure by around 40 to 60% as a function of the quality of fit. And that's both emissions and exposure to virus, depending on what the circumstances are. Why is it? What is the reason for the failure of a surgical mask? Well, here is a picture of one of my clinical fellows while she was seeing a patient. I was standing behind her and listening to her interview the patient. And all of a sudden, I realized that despite the fact she was wearing a mask, I could see her lips moving. The reason, of course, is because the mask was too big for her, and you can see these large gaps between her face and the mask. And you can well imagine that if she were infected herself, emitting virus-borne aerosol, that could easily escape around the sides or the bottom of her mask. Likewise, if the patient happened to be infected and we didn't know it, my fellow would be at risk of getting infected, because you can imagine the patient's aerosol-based viral emissions could get around those gaps and into her breathing system. So if you look at visualizations over here of respiratory emissions with somebody wearing a mask, you'll see, in fact, there's a lot of respiratory emission that is coming out the sides, out the top, and to some extent out of the bottom. Now, it is redirecting the respiratory plume away from directly in front of an individual. That might help to some extent, particularly for short periods of interaction. but there's without question a large amount of respiratory emission that is escaping and that therefore could lead to infection if you're exposed to it. And does this actually lead to infections in practice? Is this a theoretical concern, or is this a documentable true concern? We've done genetic fingerprinting with whole genome sequencing to try to work out if this is the case or not. And we've been able to document multiple cases now of transmission to and from healthcare workers despite wearing masks and eye protection. And they're all again confirmed by whole genome sequencing under a range of different kinds of situations. The other, I think, proof of the limitation of medical masks alone is that we are all aware that throughout the entire world, there have been many, many reports of hospital-based COVID clusters. Now, that's despite the fact that just about every hospital in the world has a mask requirement. So the fact that you still see clusters taking place with healthcare workers getting infected and healthcare workers infecting patients is evidence of the fact that masks are not perfect. They can lead to respiratory viral transmission. What's the answer? The answer is a better mask and a better fit. And the answer really is an N95 respirator. So this here is the analogous study that we saw with a regular mask, looking at particle penetration behind the mask, this time using an N95. Our test subject goes through the same motions, bending their head, reading, head left to right, head up and down. And you can see over here that the amount of particles getting through is almost nothing. In contrast to our 38% efficiency for a surgical mask, 98% efficiency for a N95 respirator. Now, again, we also have our clinical correlates showing that this is not just a laboratory theoretical concern, but we have epidemiological data showing us the relative protective power of different kinds of face coverings. So this was from a case control study done in LA under the auspices of the CDC to work out the relative risk of transmission depending on the kind of mask that a person might be wearing. And you can see a cloth mask lowered infection odds by around half, surgical mask by around 66%, an N95 or a KN95 by around 83%. So there's a clear hierarchy of face coverings. Here's a study showing a similar sort of finding. This is an analysis of healthcare worker infections depending upon their preferred mask type, surgical versus respirator, and its time. And really two things come out from this message over here. Number one, infection rates are higher with surgical masks compared to respirators. And number two, the risk of infection, as we've spoken about again and again, increases with cumulative amount of exposure. The more time exposed to patients with COVID, with insufficient masking, the greater the risk of transmission. You might be saying to yourself, gee, there's still a lot of infections amongst those wearing N95s. I want to remind you that that for most healthcare workers, we think anywhere from around 70 to 80% of healthcare worker infections are acquired outside the hospital, in the community. And so that still is the case if you're wearing N95 at work but not wearing anything at home or in the community, you can still get infected, of course, outside of the clinical space. There's some subtleties around quality of mask fit we can go into in the questions if you'd like to, but I think that's the explanation for why you do see infections even in the N95 population. Now, turns out the idea that you get partial protection from a surgical mask is not unique to COVID. We have analogous data even from that Occ type of airborne infections, tuberculosis. So this is an older study where they actually looked to see what was the protective power of wearing a mask for someone with TB. The way the study was done was they took 17 patients with TB and they randomized them to wear a regular surgical mask on alternate days. So Monday, Wednesday, Friday, etc., as opposed to every day. Then depending on which day it was, they funneled the air from this TB ward to two different sets of guinea pigs. One group was only exposed on days where patients were wearing masks. One group of guinea pigs was only exposed on days where patients were not wearing masks. And you can see over here that just putting a surgical mask on a patient alone was able to decrease TB transmission risk by around 56%. So, and that echoes, I think, what we've seen, which is that a surgical mask does have some value. It does decrease respiratory pathogen emission, but it doesn't eliminate it. And so the message over here is that our face coverings really operate on a continuum. This is beautifully brought out over here by this table from the American Conference of Governmental Industrial Hygienists, where they ask the question, depending on the quality of face covering that you're wearing and the person next to you is wearing, how much time can you be together before you cross some theoretical threshold where you're more likely than not to get infected? Now, again, these numbers here are a little bit arbitrary. Really, the relative numbers are the most important. But you can see over here the best protection is offered to somebody who's wearing a respirator, a KN95 or N95, and there's incremental benefit with each successive kind of mask a person might wear, as well as if you have both people masked compared to just one alone. Now, the importance of N95 respirators, of course, is well known, became well known, I think, to our government leaders here in the US. Here's Dr. Fauci with his N95s. Here's Dr. Walensky, head of the CDC, with her N95. My understanding is that the rule was for a period of time that if you want to be in the same room as the president, you had to wear N95 to establish good source control. I will say that there is a real difference in N95s in comfort. This is a picture of me. On the left is me wearing a cup-style, hard-shelled N95 across an entire medical shift over here. You can see I have lots of a little bit of bruising, some scrapes. It was not very comfortable. But there are, thankfully, soft shell models that are now available that are equally potent in terms of their protective effectiveness, but are much, much more comfortable to wear. So if you're still wearing an old, hard, cup-style N95, consider upgrading yourself to a soft shell model and hopefully reap the benefits of comfort. I want to ask a question that I think has been a little bit controversial in the infection control field, which is that should we be using N95s for non-COVID care when COVID rates are high in the community? First of all, let me just take a bit of a detour over here and talk about, again, a little bit more about what we know about the protective power of ventilation. This over here is an analysis of aerosol emissions with somebody who's doing a pulmonary function test. This is an instance of forced expiration. And what this is designed to bring out is you can see the large increase in aerosols that take place when the person breathes out. But you can also see that in a decently ventilated area, in this case it's around 5 air changes per hour, you get a rapid diminution or a clearance of those aerosols with time. This over here further brings out the benefits of ventilation relative to pressure differential. So there is a notion that ideally you want to have negative pressure if possible to minimize, to literally extract aerosol and virus from a room. And that certainly is beneficial. It turns out, though, that the amount of times the air is being turned over might be even more important than the direction of flow of the air. This is an analysis over here of aerosol burden inside of two different kinds of hospital rooms. Shown in red is a negative pressure room with 12 air changes per hour. Shown in blue is an operating room, which is positive pressure, but has 27 air changes per hour. And what you can see over here, as you measure the amount of time to aerosol clearance, is that it's actually faster in the operating room despite positive pressure because of the higher amount of air changes that are taking place. So air change per hour is a particularly important parameter. The other thing they did in this study is they measured the amount of aerosol outside the room, and they found nothing with either modality. Again, that bespeaks the protective power of distance with the additional collateral benefit of a closed door. And so that long-range transmission in a well-ventilated space is really rather exceptional. What do you do if you don't have good native air changes per hour? There's lots of data now that HEPA filters are a good alternative that can be very effective at clearing aerosol from the air. The only caveat with these is that they have to be appropriately powered and at the right setting, given the size of your room. So you can't take a little baby mini HEPA filter and put inside a large auditorium and expect it to do the job. You really have to be attentive to the size and power of your HEPA filter relative to the task that you're asking of it. So I want to bring out about a subtlety over here inside of the hospital space, which is that we know that there's a paradox, which is that the patients who are sickest are sometimes the least contagious. And this flies in the face of a conventional thinking in many ways, where we think of the sickest people as being the most contagious. Turns out with COVID, that's not always the case. The reason is as follows. We said before that viral loads are highest right before symptom onset, and thereafter they steadily decrease. And so that's correlated over here in terms of the early phase of infection, where people might be feeling fever, muscle aches, tiredness. But for the subset of patients who goes on to be very ill, it turns out that most of the drivers of severe illness are not due to persistent virus, but actually due to a body's inflammatory reaction to the infection, even though the infection by that point is often gone. But you get the residual inflammatory response that leads to tremendous amounts of inflammation in the lungs, potentially in the heart, the liver, the brain, etc. And that's what makes people critically ill. This is actually reflected in the way we treat patients. We use different kinds of treatments for people early in the course of disease, where we really focus on antiviral treatments, compared to people late in the course of disease, where we focus on anti-inflammatory treatments. But it brings out this irony that the least sick patients and asymptomatic patients are more likely to spread infection compared to the very sickest of the sick. This is brought home as well by measurements of viral burden in different kinds of populations. This over here is looking at average viral loads in inpatients, sicker people, outpatients who have mild illness, healthcare workers who often have the best access to testing, get tested earlier on in the course of their disease. You can see actually that paradoxically, inpatients have very low viral loads, outpatients moderate, and healthcare workers, because of early detection, can find very high viral loads. So it turns out, again, that the greatest risk of transmission in a hospital setting is probably not the very ill COVID patient. It's more likely to be the asymptomatic, pre-symptomatic individual not known to have COVID, be it another patient or a healthcare worker. This is mirrored by measurements of SARS-CoV-2 in the air in different settings. This over here is air sampling for SARS-CoV-2 on the one hand in an intensive care unit, even with different kinds of respiratory support mechanisms, compared to at home. You can see at home, the levels of virus are much, much higher. Again, bringing home the idea that less sick patients, paradoxically, might actually be more contagious compared to more sick patients. It's also borne out by analyses of where do healthcare workers actually get infected. This is based upon a study in the University of Wisconsin where they did sequencing, again, genetic fingerprinting, to try to work out source of infection. As we said before, most healthcare worker infections are attributed to the home or the community. However, the transmission that does take place in the healthcare setting typically will come from a co-worker or from patients without known COVID, either in the context of a cluster or a non-cluster. And so again, it's the unappreciated, the infected person who's below the radar because they're feeling fine, that it actually presents the greatest risk of transmission. This is mirrored as well by analyses of where do hospital COVID clusters occur. You might have thought that they occur on COVID wards where people are continuing to expose to COVID positive patients. The answer is no. It's very rare actually to have a COVID outbreak on a COVID ward. They're much more common actually in outpatient clinics, in ancillary services like radiology, non-COVID inpatient wards where you have people with unappreciated COVID infection, or the emergency department. Finally, I want to talk a little bit about vaccination. We know that vaccinations, of course, have been incredibly potent in preventing severe disease and deaths. A controversy has been, do they also have a role in preventing transmission? This is an evolving story as we change our vaccines, as we change the variants that are circulating. So I'll share with you some data on this, although this is data that continually has to be refreshed as we go through different phases of the pandemic. So point of evidence number one over here is actually from the United Kingdom, where they've done periodic cross-sectional analyses of the entire population, or say a large sample of the population, about 100,000 people, just working out who's a carrier and who's not. And turns out that unvaccinated people are about 3 times more likely to be carriers of COVID compared to vaccinated people. So an unvaccinated person is more likely to be a carrier compared to a vaccinated individual, compared to a vaccinated individual. The other thing we know is that even if you do actually get infected with COVID, despite your vaccine, vaccinated people clear the virus faster. So again, this is analysis over here of time to clearance of virus. You can see in the unvaccinated individuals, it takes more time. It's a slower amount of period until clearance of the virus compared to those who are vaccinated. So an unvaccinated individual is more likely to carry virus. And when they do get infected, will carry the virus for longer, therefore allowing for more opportunities for transmission. Then finally, again, if you look at household analyses, you can actually see the protective power of vaccination over here. This is the secondary attack rate amongst almost 8,000 household contacts of almost 5,000 people with COVID in the Netherlands. And you can see that the greatest risk of transmission, the highest secondary attack rate, was if it was an unvaccinated source exposing an unvaccinated individual. But so long as one or both parties was vaccinated, the risk of transmission is dramatically decreased by about half. Finally, I just want to make the point that although I think we've learned a lot about what it takes to protect an individual from COVID, and I'll summarize that for you in a moment, I do want to acknowledge that we're in a different space now in late 2022 compared to where we were in spring of 2020 in terms of what's the actual risk of morbidity and mortality from COVID infection. And while I would say that from a first principles point of view, no person should have to get infected at work, and therefore maximal protections, in my opinion, are fully warranted, I do think that as you think through your own personal risk calculus outside of work, that you might want to take some of these data into account and make a personal decision about what's right for you. So this is looking at the rate of COVID deaths by vaccination status, according to whether you have no vaccine, just the primary series, 1 booster, 2 booster. And you can see over here that the morbidity burden is disproportionately to an enormous degree being borne by the unvaccinated. This also brings out over here the marginal benefit of getting a second booster if you've only had one. It does lower death rates even further. And so if you're in the 2 booster category, the risk over here of a bad outcome happily has become very, very low. And it's tiny compared to what it is for an unvaccinated individual. Even if you do get a breakthrough infection, you're admitted to the hospital over here, this is showing us over here that the COVID mortality rates, even amongst that subset of individuals who are sick enough to go to hospital, has come down enormously. So you can see that at the very start of the pandemic, the mortality rate for somebody hospitalized with COVID was around 20%. It is now well below 5%. Now, listen, I don't want to take a 5% chance of anything of dying, so I'm not dismissing it, but I do think this is helpful context, again, as you think through your own risk calculus around the broader life that you might be taking outside of work. Finally, it might be helpful to know who actually is at risk still of dying from COVID despite a booster, because I think this is the population where I think it's very clear that maximal protective measures are absolutely still warranted, and that the greatest risk factor, and this is an analysis over here of deaths from the United Kingdom across I think a 4-month period at the beginning of this year, that age is actually the greatest risk factor for death. So if you're over age 70, 80, that's when the risk of deaths really increases. The risk of dying below that age, while not zero, is incredibly low. And in terms of medical comorbidities are the other real driver of mortality risk over here. This is from the same study where they looked at the risk factors for deaths among people despite getting a COVID booster in the Omicron era. And you can see that the population really at persistent high risk of really bad outcomes from COVID is the immunocompromised. So people with immunodeficiency, cancers, as well as people with a lot of severe comorbidities, such as over here, neurological disease, lung disease, dementia, liver disease, so on and so forth. So as you think through your own personal risk profile, it's really a function of your age and your medical status and your vaccination status. And that should enter into your thinking about what kind of risks are tolerable or not tolerable for you. So I want to summarize over here. There are factors that increase risk. There are factors that decrease risk. So factors that increase risk is high community incidence. There's a lot of COVID going around. You're at increased risk of getting infected. Higher viral loads, more symptoms, proximity, longer duration of exposure, poor ventilation, lack of masking, and lack of vaccination all increase the risk of getting COVID. But the opposite is protective. So these are the factors that decrease risk: low community incidence, lower viral loads, lack of symptoms, distance, brevity, good ventilation, mask on the patient, mask on the provider. N95 is better than a KN95, is better than a face mask, is better than nothing, and vaccination. And with that, I thank you, and I'm happy to take your questions.
Thank you very much, Dr. Klompas. I must say I've been following the literature for a long time, and the way you summarized everything is just telling the story just so beautifully. And I really want to thank you for that. And I was wondering if anybody had a question that they would like to ask. I see some in the chat, but I'll let people unmute themselves and ask first. Yes, I see a hand up. C. Nenza Grover. I don't hear you. I see another hand up with no name. Speak, please.
It might be me, John.
Oh,
Dorothy.
okay.
Let me
Hello,
turn
Dorothy.
the video on so you can see me. Thanks to both of you. These, as somebody who has been paying attention to this pandemic more than I would have liked to, perhaps, I'm grateful to both of you for all that you've shown us here today and talked about. Mike Klompas, one of the things I'm curious about, because I'm an occupational hygienist, and the question I put in was, why are these larger particles called droplets? because for me, in my training, and for perhaps for aerosol scientists and some others, they're all aerosols. And when we start calling the same things different names, it means that people have different interpretations of what the word means. And I know historically, infectious disease folks see droplets in a quite different way than I do, or John might, because we're both hygienists. So I'm curious about the history on that in terms of your training, and how that's then affected how you've understood transmission.
Yeah, it's a really good question. I think it's a historical artifact. I think it predates my entry into the profession. There are a couple of papers that are out there trying to explore that history and talk about the ways in which perhaps misinterpretation of earlier science might have led to that that mislabeling and language that creates this sense of an artificial dichotomy that actually does not exist. And I think it continues to be a problem that we have this language, because I do think it leads people down different kind of mental pathways that ultimately don't match what we know about the science at this point. So I think it's a problem. John might have more perspective on the historical origins of the terms that he might wish to share. But I think that we're ripe for a change in terminology.
Okay, thanks. And if I could just ask one more question. You talked about N95s, but certainly in late 2019, the National Academies of Science came out with this big report saying that elastomerics, the traditional respirator with canisters, were a good idea for healthcare workers. And in fact, they've been used in places like the Infectious Disease Hospital in Texas for 20 years or something like that. Yep. Have you seen an increased use in elastomerics or in PAPRs, the powered air purifying respirators, instead of people using the throwaway N95s or KN95s or things like that?
Yeah. I'm aware sort of scattered examples of institutions that really embraced elastomerics or PAPRs. It's been the exception rather than the rule. As you know, in terms of protective power, they are as good, if not better, than an N95. The limitation, I think, has been for hospitals is around just management of reprocessing and storage and supply. So that from just a practical operations point of view, they are felt to be more difficult to manage for a large population of tens of thousands of healthcare workers compared to the N95s and other respirators.
Some people might look at both the short and long-term costs and say that there's actually a benefit. I think Simon Smith has showed this, that long-term costs of PAPRs and the elastomerics are actually quite a bit less than if you keep throwing out N95s.
That makes perfect sense. I mean, I think that it's not just around cost; it's also around logistics. So the elastomeric, as you know, has to be disinfected. And who's going to do that? And if it's going to be the healthcare workers, will they do it effectively? Will they do it at all? Right? We know this is sort of a challenge with other parts of pieces of medical equipment. If you get a PAPR system, where's the central storage location for them? How are you going to get the floor? How are you going to do it on a timely basis? It just turns out that it's a real headache for a hospital to absorb that into their operations. Again, there are, without question, some specialty locations, some hospitals that have chosen to go that route, because I think, as you point out, depending on your lens, it can be very advantageous, but I'm just conveying to you some of the reasons why I don't think it's been very widespread.
Yeah, if I can add, the other problem is setting up the logistics in the middle of a pandemic is not the optimum. This is something you need to sort out before a crisis happens, not in the middle of one.
Great, thank you.
You bet.
Well,
I had a couple of questions. Thanks very much to both of you, and it was a fantastic overview of the science and of the knowledge and of sort of how we can apply it to make workplaces better. So actually, one of my questions, Dr. Klompas, is whether you've been able to apply this knowledge in your own workplace to, you made reference in one slide to an outbreak at the hospital, but are people still wearing N95s or other filtering face piece respirators, is this, I guess, have you been able to, because bring the science to your own workplace or other workplaces that you're involved with, like the university?
What we found is a tremendous diversity of the way different hospitals have reacted to this data and the kinds of policy they put in place. We actually recently published a survey, I think it was just under around 24 different kinds of leading U.S. academic hospitals on their COVID infection control policies. What they used for COVID care was an N95 or a surgical mask. What they used for non-COVID care, what was the role of testing, what was the role of HEPA filter, so on and so forth. And the take-home message was a massive amount of diversity. Unfortunately, I'm not king, so I don't get to do what I might want. And so my sort of my personal values, my understanding of the science, and my ideals have to counterbalance against what my colleagues might think and what the hospital operations system is willing to absorb, and their sense of, just in a real politic kind of way, what's worth doing and what sort of risk are they willing to tolerate in order to gain an operational counter benefit. I mean, it turns out that for many of the interventions that might be ideal are associated either with operational impediments or with high cost. So that there's an inherent tension over there. And again, different systems, depending on what policy we're talking about, have fallen in on different ends of the spectrum. I just got back from traveling in Germany, where you need to wear a respirator to go to the bus. Mm-hmm. Contrast that with what's taking place in some of our hospitals, where in some cases you don't have to wear anything at all, and at best maybe a surgical mask or a medical mask. So different institutions, different cultures, different countries, they really attack this in very different ways.
Yes, I was impressed with Germany making a policy decision as of the beginning of October because of the winter season, because of climbing rates. They were going to reinstate some of those non-NPIs, non-pharmaceutical interventions across the population, which hopefully will protect their citizens. But I think everybody on this call, looking at all the names, we're all trying to apply the science in our workplaces to a large extent, despite the sort of popular mythology of the risk being diminished, or else we just have to live with it. So, John, have you got any other questions, or do you want?
I have just one comment. So one thing that I've been struck with, especially in Canada, when we've had these, well, in the US too, these wildfires, and the recommendations for the population to wear respirators during smoky times and things like that, that wearing an N95, being fit tested, finding the right respirator that will fit your face and is comfortable and can last, is really a life skill. And this should, there's all kinds of work that's done in the workplace or at home, renovations, etc., that's dusty, and it's really brought home not just for infection control, but for all kinds of protection, that respirators should be a life skill that people are taught.
Yeah, it's absolutely true. I have an issue with seasonal allergies, and wearing an N95 outside during pollen season, I've found it been really, really helpful. So you're quite right that this is far broader than just respiratory viruses alone.
Ironically, in Ottawa, when we had our protests against masks, the diesel trucks emitted so much particulate that we had air pollution that warranted wearing masks for the diesel particulate. Anyway. Any other questions?
I have one more, but if someone else, but then I also know, Dr. Klompas, you want to go. Kevin, you have your hand up. Do you have something you want to ask quickly?
Can't hear you.
You're muted.
Still muted.
This paper
Okay.
that I posted in the chat site. It's an amazing paper. Like it's only 10 pages, but if you're looking for some really good guidance, this is just everyone else. It's well worth reading, and I just want to say thanks so much, Dr. Klompas, and for John, to John for presenting today. Thanks.
Thanks, Kevin. So that's a paper that Dr. Klompas is the author, you mean?
He's one of the authors. It's the name of the paper is Prevention of SARS-CoV-2 and Respiratory Viral Infections in Healthcare Settings, Current and Emerging Concepts. But you know, just looking for guidance, it's a goldmine. There's some great information in there.
Nick, I see, has a question, which was actually what I was going to ask in even more recent terms. So he's asking, many of the studies are pre-Omicron. Does Omicron make a difference? And my question was, well, now it's 10 months of Omicron, all this variant soup, as they are calling it now, which is more and more, sorry, someone's calling me. I don't, more and more transmissible, although I think that's a lot to do with immune evasion or waning. But I just wonder if, I guess, is the urgency any higher? Any comment, I guess, around Omicron and what you've cited, and even as things seem to mutate?
Yeah, no, it's every day is a new day with this this virus. So as you point out, I mean, the defining characteristic of Omicron and its relentless sequence of variants is greater transmissibility. And that makes sense, of course, because I think biologically within a population, what's going to lead to a virus being successful is if it's able to spread more efficiently compared to the guy next door. So, and what I would say is that the same principles apply in terms of quality of respiratory protection, quality of ventilation, importance of vaccination, but only more so. So I can't give you precise figures to say exactly how things have changed, but in theory, say you could have got by with the original strain out of Wuhan, the ancestral strain, being in the same room with the person for half an hour without getting infected. That amount of time, the amount of exposure you could stand before you get infected now has been substantially diminished. I can't tell you exactly how much, but I think that's a way to think about it. So before it might have been that you had adequate protection at 6 feet, now you need more. Before you might have been adequate protection with this much time or with this much quality of mask fit, now you need that much more, or you have less of a margin for error.
Okay, if I can just add one quick question at the end. Here in Ontario, they're comparing COVID to the flu. You gave a slide which showed that the severity of getting a COVID infection for a serious disease has gone down. Is it at the level yet of the flu, or have we got quite a ways to go?
Yeah, no, that's a really good question. So we actually do have data on this where we can look at the comparative risk of hospitalization or death with flu compared to COVID. And it turns out it matters enormously as to what your vaccination status is. If you're unvaccinated, COVID is a far more deadly disease than flu. No, hands down. If you're fully vaccinated and boosted, then the risk of hospitalization and death per episode is actually the same or less than flu. The one caveat being that because COVID is continuing to go in large cyclical waves, that your cumulative risk over time might still be high. I mean, so your per episode of COVID risk, again, fully vaccinated, fully boosted, is low. But if you're going to go through that risk on a repeated basis again and again and again, because as with by wave, collectively it might add up to something that's more in the that's more. So that's sort of the subtlety around that issue. Now, I think the different ways of thinking about that, and again, I think personal values over here have a large role to play. And again, I'm talking outside the workplace, because again, I think in the workplace itself, I think there's an ethical imperative that nobody should have to get sick. But outside the workplace, as you think about what sort of risk you're willing to tolerate for the collateral benefits of socialization or being with your family or traveling, whatever it is that we do as human beings, I think that it's worth sort of thinking the way that you might have thought about flu and other respiratory viruses. I think that historically speaking, we just weren't that explicit in our thinking about those risks. So we did things that put us at risk of getting flu and other viruses without really knowing about it, because it really wasn't on our radars the way that COVID is now and the way it's brought other viruses onto our radars. And we accepted, going to a Christmas party or something like that in densely crowded indoor space, and we didn't think too much about it. And now we can think differently about it and say, what's my willingness to get COVID? And quite frankly, what's my willingness to get flu, right? Because I think that same equation might apply. And I think that reasonable people could come to different conclusions on what they're willing to accept relative to what benefit they get. So to give you an example, when I travel on an airplane, there is no benefit to me whatsoever to being unmasked. I don't need to talk to anybody. I don't find it uncomfortable. I'm wearing my N95, there's no debate about it. Okay, but if I'm going to go to a close family gathering where there's high value to me being unmasked, in the context of being fully vaccinated and otherwise healthy, I could see somebody saying, okay, in that setting, I choose to accept that risk, knowing that I might get sick, because by virtue of my vaccination, my underlying health status, I might not get intolerably sick. I think that's a very, very personal equation that each person needs to make for themselves.
And if I can add to having a mother-in-law who's 92 years old in a long-term care facility, I need to be careful for her.
Yeah, 100%.
And,
Absolutely.
yeah.
That's part of the equation as well, without question.
Yeah. Kevin, last one.
I know you've got to go, Dr. Klompas, and I'm really grateful for you just hanging around. Just the question, I think it's an important question in my view. I've been infected with COVID once. And so if I get infected a second time or even a third time, does the risk of go up? The risk of me having more severe symptoms and being hospitalized go up?
Actually goes down. So a natural infection in some ways confers some of the benefits that you might get from a vaccine, that it boosts your immunity to that particular strain. So it's pretty clear that somebody who's been recently infected does get protection against future events and future hospitalizations. Again, the wild card over here is the variants. So for example, we know that if you were infected pre-Omicron, that your protection against a BA5 infection right now is minimal, maybe 20% at best. However, if you were infected with Omicron at the beginning of this year, you might have on the order of 70%, 80% protection against a BA5 infection right now. So again, what you're infected with and when you're infected makes a huge difference. But in general, infection confers future protection.
Thank you.
Okay, time to wrap up. And thank you very much again, Dr. Klompas, for a very helpful and very nicely done presentation. I've seen lots of presentations over the last 2.5 years, and this was one of the best ones that I've seen. And thank you again.
Okay, thank you all so much.
Yeah.
All the best.
Thanks for joining us, and thanks everyone else again for joining us on the Friday before Thanksgiving. Happy Thanksgiving. Want to remind everyone we have another conversation next Friday with Krista and Dr. Roy McKay, who has many interesting war stories about fit testing and about the use of various types of respirators in all kinds of occupations and industries. So I highly recommend that you sign up for that if you haven't been able to yet. And we will post the video. The video from today will actually be live on Facebook in a matter of minutes, and then we will break it down into a playlist, hopefully with the slides, and post on the website next week. So thank you again, and as I said before, happy Thanksgiving, and we'll see you next week. Bye.
Here. Bye.